So it extends it to the next level as well, not just what's happening in the comm center. And we even, they've even been, standing by as the SWAT teams there trying to negotiate with somebody instead of having a really negative outcome. Their team has assisted the law enforcement team or the MS team in having a much more positive outcome.
That was Sharon McDonough, director of the Tucson Public Safety Communications Department, about how co-locating trained crisis professionals in the Tucson 911 Center has enhanced resources and positively impacted outcomes for individuals experiencing crisis. I'm Matt Eckhoff on behalf of the Vitalist Health Foundation to explore Tucson's experience with 911 and crisis co-location. Sharon and I were also joined by Amy Devins, First Responder Services and Urgent Engagement Supervisor with Arizona Complete Health's Justice and Crisis Systems team, as well as Anna Corcoran, Administrator with the Tucson Public Safety Communications Department. Thank you for joining us today as we take a deeper dive into the Tucson and Arizona Complete Health partnership that continues to impact the trajectory of individuals experiencing crisis across the Tucson region, and how resources for public safety systems are available now for communities of all sizes across Arizona. On the national stage is the City of Tucson and the Public Safety Dispatch Center. Did I get that right, Sharon?
It's a public safety communications department.
Little background. Sharon, your department, the stats that I saw most recently in the last year, under the emergency call category, there were about 700,000 calls for emergency services. Is that right?
That's correct. Yeah, we're just over 1.2 million calls coming into the center. So those are all the calls coming in, and that's kind of one of the complexities of a 911 center is we get a lot of calls where people are like, I don't really know who to call, so I'm calling you, and can you help me? So a unique ability to get that caller to the resource that they need that perhaps isn't an emergency resource is something every communication center is faced with across the country.
A lot of people are calling you, and it's your job to then differentiate how you're going to get the resources that an individual needs. And I guess at this point, enter Amy Devins from Arizona Complete Health. Hi, Amy.
Hi there.
Can you tell us a little bit about how co-location works between Arizona Complete Health and the City of Tucson?
It was 2015, 2016 when we started to kick this idea around. As Arizona Complete Health, we're one of the regional behavioral health authorities in the state of Arizona. With that means that we have responsibility for the crisis system. The crisis system itself is a crisis line, mobile teams, and those observation units. So the place where you call, the folks that come out to the scene, and then the place where you can go. We started to work directly with our law enforcement partners and our fire and EMS folks in the field. But then we started to realize, hey, it'd be great if we could actually get in front of these calls. So we started to shop the idea around with our various public safety answering points as an opportunity to maybe take some of our crisis line staff and co-locate them inside one of the public safety answering points, our 911 dispatch centers. Tucson was the very first place that was really super interested, way ahead of anybody else in the state and certainly around the country. There was a few folks trying this out at the time, but Tucson was first to the team. So we explored the idea and very quickly moved crisis line staff inside their call center. So they are answering crisis calls that come directly off of the Tucson 911 system, as well as other public safety answering points.
Sharon, when did this, so 2015, 2016, Amy, you said you started shopping this idea. When did it really kick off, Sharon?
I would say we were up and running in a meaningful way about late 2016, and our numbers have done nothing but increase. And Amy kind of hinted at it that, we are a regional communication center. So even though there are other public safety answering points around us, anytime they get a need for a crisis, they just send them over here because they know we have those crisis call takers in the center. So to date, about 1,200 calls per month goes directly to crisis, the call takers in the center. And basically comes off the backs of police officers who are, they're just not the best equipped resource to deal with a person who's in a mental health crisis. A trained professional in crisis is the best resource. So our ability to immediately hand them to that appropriate resource Feels good to us. We had to get our team to trust that resource as being reliable and ready and capable. So having them sitting here in the center has allowed them to just converse and understand each other. And then they feel really comfortable saying, yeah, I'm gonna hand it over because I know that person's capable of giving this individual, this caller, what they need in this moment. And I'm not, and neither is a police officer or a firefighter. So one great thing about Amy's team is this becomes an entrance point for them long term. So even though the next phone call maybe is not a 911 call, it's the connection to the person they just talked to last time. Now they've set up a regular meeting, they have an ability to check back in. They get them connected to meaningful long-term solutions instead of just give me the Band-Aid for today type of moments. And to me, that reduces frustration for the field responders because, you know, the field responders, they want to solve the problem. And it doesn't feel good to them when they know they're just going to see this person the next day again, because they never got connected or navigated or entered into a system that's really going to be meaningful in the solution. So Amy's team is fantastic. That's a big deal for us. We know that so many of these calls are not emergent, and our ability to have a sorting mechanism that includes things like it used to be police and fire, and most comm centers are, do I send it to police or do I send it to fire? Well, we now have police, fire, telemedicine, crisis, and 311. And then from 311, you have a whole nother menu from there. And our ability to really get that person to a resource. Crisis being the first one that entered our system in a meaningful way to allow my team to have trust in that ability, that this is the right thing to do, not send a police officer, not send a firefighter. Huge to us, huge. Of all the things we've ever done in this center, I think long-term that is meaningful to our community, this is the one.
It's a holistic approach, right? And it's not just in crisis. It's allowed us, to Sharon's point earlier, one of the other unintended consequences is that when we did introduce telemedicine and introduce some of these other initiatives like 311, it helps us with that trust that's built between the 911 operators and the different systems to say, right, there's more options now than just police and fire and EMS. There's police, fire, EMS, crisis, and now we have other community resources that can help us. And so having the crisis specialist co-located in the 911 center has really helped us build that trust with our staff, with them, knowing that we're putting professionals on the other side. We're very type A in the 911 center. We like to take care of our community. We like to take care of our first responders. And so a lot of times we hated to pass that caller along because we want to make sure that they're taken care of. And we want to make sure that our community member gets the best service. And so in our minds, right, we're answering the phone, that's us. I get to provide that best service. But when I have somebody sitting next to me that I can give that call to, it just elevates that, and it allows us to build that relationship. Not just for me when I need it to turn around and say, man, that was a tough one, help me work through it, but also knowing that I've provided that service that is best needed for that community member.
I'll jump in on that as well and say, this is available. So what we've done in Tucson, we can scale this. So from my perspective, when I hear the successes, it makes me think we should be doing this everywhere. So this is available in Arizona. So if anybody else is, watching this and wants to reach out and get in touch with any one of us, we're happy to share this information. I have a whole team of folks throughout the state that are out there trying to make contact with our first responder leadership, as well as everybody else along the way. So if anybody's interested, let us know. I can tell you exciting news on the horizon. We just entered into an MOU with Flagstaff 911 to do a similar model, scaled a little bit smaller because, call volume will dictate, but we're going to be launching that very, very soon. We're looking for another place as well in the northern part of our state. So, this idea that it can only happen in metropolitan areas or in our largest cities in Arizona, I'll just say we can do this anywhere. We can scale it to fit the needs of the communities that are interested in doing partnerships like this. We can do virtual co-locations, but I do believe, the sentiment here is that so much growth and so much trust has been built in this partnership by having folks not just us be connected to each other, but the folks answering, the folks on the front line, really starting to grow trusting relationships and understand what happens on the other side of that fence. Behavioral health can be extremely hard to navigate. It can be very difficult for families, especially when someone's having their first crisis. Having somebody understand who to reach out to, they can reach out themselves, their family members can reach out on their behalf. That's okay. We don't look at someone's crisis as if, that didn't quite rise to the level of being a crisis. We really say anything outside of somebody's ability to cope can be a crisis. So with that, along the way, if that means that law enforcement needs to be dispatched, but a mobile team should also go, that's totally fine. Sometimes the call can completely come over to crisis and it never hits the board. That's fine too. Honestly, most of the time when a call just completely gets transferred over, it very seldom gets bounced back to needing a first responder. It's around 2 to 3% of the time. So the other cool factor in there, we thought when we started this that we were going to know a lot of the folks that were getting transferred to us. That is not the case. Usually the folks that get transferred off of a 911 system over to crisis are folks that have never encountered the crisis system before. So what that means is we're having this opportunity to help them before they become criminally justice involved or any further criminal justice involvement, or before they start to churn and end up in emergency rooms, because those are the two likely places that somebody would end up. In addition to that, I would say, our first responders deserve a little bit of support in this, right? I don't expect enforcement, fire, EMS, I just don't expect them to be crisis professionals. They have great skills, but having done the job myself, I'll say, man, there were some times that I was like, I wish there was somebody else here that could sit with this person for an hour or so and really, talk them through what they're experiencing. So with all of that, it is my passion now. This is what I want to do. I want to make sure that we have a crisis system that's so robust that it will eventually be regarded as an emergency service.
You spoke, Matt, a little bit about community well-being, and I just want to take a moment to talk about the downstream effect of what happens here. When these people are sourced correctly to a meaningful resource like this, immediately and correctly. So in the moment of crisis, you need to connect them now. They can't have an appointment a month away. Just, we all know that doesn't work. So our ability, the long-term connection point, has downstream effects that are immense. It makes my 911 system more reliable. It means I have a freed up call taker, so now I can answer calls quicker. It means there's a police officer or 2 or 3 or 4 who are available for, the more critical, life-threatening calls. It means fire EMS is available to the heart attack down the street. It means the hospital isn't clogged up with someone that they don't really have a great atmosphere to help. When we bring a crisis person in an ambulance, because ambulances can only go to hospitals, we put them there in an environment that's loud and noisy, and we expect them to be okay in their moment of crisis until we can get a crisis resource to them, instead of getting them directly there without all of this extra. So the downstream effect and how it affects the community, its well-being and holistic health is huge. And that's the stuff that's even hard to capture. But we know it feels right. We know these people don't belong in an ambulance going to an emergency room or in the back of a police car going to a jail. Where they belong is connected to the crisis resources. Our partnership allows that to happen. When we first started talking about this, Amy and I, we called it ground zero or
Sub-zero, I think. Sub-zero.
Yeah, sub-zero, like before they first enter the system. And that was the key magic point, was because once the firefighter has this person, they have one question asked: do you want to go to the hospital or not? And once the police officer has this person, it's: do you want to stay home? Do you want to go to jail? Right? Like, we're limited on what we can do. Now we've gotten better and more robust, where police and fire, even from the field, can access these resources now too. But again, it all started with the trust that started here with these relationships. So it's such a huge thing. That's why you hear the passion in all of our voices. And I agree with Amy, this should be in place everywhere. We know that behavioral health crisis is a huge impact to all of these emergency systems without a good resource embedded in those systems.
Oftentimes, I refer to this type of conversation as the train has left the station. We have a best practice here that is already moving down the rails. And there are a lot of communities, and Amy, I'm so glad you talked about out of urban centers, because I think we have so many, communities, not just here in Arizona, but I hear from folks all across the country that we just don't have those resources here. But we're talking about the resources that are available right here.
Right.
You make it sound real easy, but a lot of groundwork went into this. I mean, when we talk about the politics of this, cultural shift of this, stigma of mental health, whoa, Amy,
Yeah.
take us to the
Yeah.
beginning of a
Yeah.
community that's just saying, forget it. I'm not even going to start this conversation because there's a brick wall in front of me. How are you getting through it?
Yeah. I will say we still encounter those barriers. The cool thing is that it is my job to break down some of those barriers and to be consistent. And, again, I've worked with Sharon for years and Anna for years talking about this stuff. And I want to say, if we go back to the dawn of time, it almost sounds a little too good to be true. But truly, in Arizona, the way that we're structured financially around Regional Behavioral Health Authority, structuring with our, with access that our structuring and our funding allows us to be that oversight body that creates this concert of services, and we have responsibilities for ensuring that they run smoothly. And when you have those responsibilities, you obviously take them very seriously. We report to Access. So, there is there's no way to just do this in one little corner of the state. And, we definitely pilot things, but we want to make sure that if I'm modeling something, that it can be done anywhere. So to what degree our first responders are interested in engaging, and those first responder agencies are interested in engaging in some crisis innovation, some crisis call diversion, deflection, we are standing there ready to say, yeah, let's do that. If there is anyone that has an idea, they want to stick their toe in that pond and say, let's try it a little bit, we're happy to do that. We are extremely data driven. We are funded for these services. I am selling nothing. This is not a sales pitch. This is yours in the state of Arizona. I can't speak for other states, but I can say with some authority here, this is our responsibility to ensure that our first responder agencies, our community members understand what is available to them. We monitor for that volume, the response times. We have mobile teams everywhere. I will say this, the crisis system tends to be a little bit more discreet in its approach than maybe, law enforcement, fire, EMS. They're coming with licensed sirens, uniforms. It can be very obvious when they're around. On the crisis side of things, it's significantly more low key, and significant amount of crisis stabilization can be done telephonically. Sharon talked a little bit about telemed as an option. If someone wants to only engage by phone, that's okay. If someone says, I want a mobile team, that's okay as well. So if a first responder is out on a call for service and it looks like one certain call type, and halfway through that call, they say, hey, I want a mobile team out here, they can have a mobile team. So we come from a place of yes. That to me is the key to all of this, is that we say yes. So if there's anybody out there that wants to know more, we are excited to share.
And it creates this, symbiotic relationship. Like, when you talked about barriers, when Amy and I sat and talked about these things, we talked about those barriers and said, okay, now how do we get over it or around it? Like, what do we do next? And one of the things I said was, well, you need more crisis teams. Like, you got to give me more. They got to get there faster. And she goes, well, you got to prove a need for them or I can't get more. Right. So there's a level of understanding that comes that starts to prompt that. We've all got budgets, we've all got bosses, we've all got the system of things that say, hey, we don't want a wasted resource. You got to prove the need. Well, us being able, they are fantastic at collecting data off of this. And that was a big piece. And we would like to say, we're pretty good at collecting data too, to say, if I know that her system is going to take all these calls, if I can give her one more resource or dedicate a different phone line within my center to them, I know that that affects the system at a bigger level, and that's symbiotic. I've got to tell that story. And I think a lot of agencies are busy in their silos saying, we do this part. If you just send them to us, we'll do our part. But really what the talk has to be is, how do we all affect each other, and why is that meaningful? And how do we capitalize on that and make that even bigger? And I think that's what we've done right here.
Vitalist has referred to it as the elements of a healthy community. As a public health guy, we talk about the social determinants of health. And Sharon, you talked about downstream. We're talking about access to care. You just happen to be the point at which people are seeking access to care. So what are you seeing, I guess, Amy, specifically for you with the onset of 988 and other kind of access points for crisis care? Are you seeing a shift to where people are getting or swimming further upstream and getting that care and support and I guess lack of access to the justice system and more access to behavioral health care?
Yeah, I think 988 has really raised that water level. It has created a conversation nationwide about crisis systems of care, and that it helps point out that we can't just be a crisis line, that we can't just have a mobile team or multiple mobile teams in a certain area, that there needs to be almost a universality to it, right? There needs to be observation units. You need to have a place where somebody can go, they can walk in and not be told no. So those types of things, the general person on the street, if you ask them, do they know anything about the crisis system, that can be kind of a nebulous conversation. So like the brand 988, I think, is extremely helpful in understanding, package it up, because it's similar to 911, the way that our minds think about that. The cool thing in Arizona, if you have an area code that's an Arizona area code and you dial 988, you will get routed to the call center here, which happens to be the same provider for both our statewide crisis line and also for 988. So our statewide system has been in place long before 988. So, we're kind of capitalizing on each other's momentum. My hope is that at some point, someone will, not call 911 and they'll instead call the crisis line, or they'll instead call 988. But here's the thing. If they choose to dial 911, we have systems in place where we're connected to each other so we can help support that person and route them. The other part that I'll say is live answer is important. And I know there's a nationwide conversation around that sort of live answer, IVRs, and press 1 to do this, press 2 to do that. That can be daunting. Being put on hold can be daunting for someone experiencing a crisis. So for us in the state, we really try to emphasize that we are live answer. These are human beings working 24/7, answering the phone and trying to help somebody through that crisis. Again, substance use, co-occurring, never engaged in crisis services before, adult, youth, from the state, from outside the state, from outside the country, speaking a language other than English, any of those things. I don't want anyone to have a message from this that they will be refused, because they won't. Crisis is funded. I want folks to be able to reach out and feel like they have a place that they can talk to somebody.
I'll add to that just real quick on the 911 side, right? We take this stuff because sometimes people don't know what they need. And so they'll call about a family member, or sometimes themselves just having some sort of feeling and they're not sure what to do with it. And so just knowing that we have somebody on our side that we can say, hey, I don't have to redirect you to hang up and call a different number. I have somebody in the center that I can connect you with right now that can help you. That is not a police officer. That is not somebody with a gun and a badge or a big red fire truck that's going to show up, right? Like, they're going to give you the service that you need because it's not a medical emergency, or it's not a law enforcement emergency. So just having those types of connections within the 911 center, because people don't know. They don't know what they need sometimes. And they don't know, should I call crisis, or should I call 911, or is this a 311? And the beauty of us here in our center is that you can call 311 or 911 and you're connected. You're connected, you have it, it's right here. You don't have to call and hang up. You don't have to be afraid that you're going to get somebody with a badge and a gun, or, you know, or a firefighter or paramedic. You're going to get the resource that you need. And so, so we're very proud to have the crisis specialist in our center, and to have this partnership with Amy and her team, because it just helps provide a completely different level of service.
You know, and to Anna's point about people not knowing what they need, that is just so true. And we don't, one of the things we do uniquely here is we don't say, do you need police, fire, or EMS? We say, what's happening there? Because they generally don't know what they need. I'll give you an example. We had a gentleman call into 911 679 times in 8 days. He never said he had a mental health issue, but I'm guessing that we might think he does. Something's going on, right? And he was one that we handed over to crisis, and in fact, their CMT team followed up with him in a really extensive way. And as far as I know, we haven't heard from him much lately, but obviously something's going on. He never called in and said, I'm having crisis, but we could tell by behaviors because of some training and some of our time sitting there with the crisis call takers in the room. But something's going on with this person, and we should get him connected to a different resource than a fire truck or a police officer.
And that's a great point, because in the background, so when we first started with Tucson, we had another little side conversation that was, hey, what about your familiar folks? What about your most frequent callers? Do you have a sense of who those folks are? And we started to kind of explore that as an option to maybe do another type of partnership. So, you know, secondary to having folks in there, our crisis specialists co-located, we still have this opportunity to help some sort of churning in that 911 system. They're getting their needs met. They're creating opportunities to figure out supports, but the system itself historically hasn't been very good at identifying what that need really is. So we say, from the crisis perspective, well, let us pitch in, right? So let's figure out, are they our member? Are they known to us? Do they have a clinician? Because frankly, the 911 system and the emergency systems of care don't directly communicate with crisis, outpatient service providers, inpatient service providers. Those are two systems that, you know, traditionally are not going to share information back and forth. And certainly we are protecting people's privacy. I will say, though, there is almost a finger pointing that happens. And I know I used to do it when I was a patrol officer. Why is it's not working? Their outpatient provider it's not working. Well, maybe they are making all of their appointments. Maybe they are, you know, they are taking their medications. They come to their group sessions and they seem to be keeping their job. But on the weekends, or maybe something else happens during the week where they need some additional support and stability, and they're seeking that support and stability through 911 and the services that are traditionally attached to that, rather than connecting to their outpatient provider. So sharing that information across when it pops up, I mean, that's really looking at the person's holistic needs, right? It's demonstrating for both sides, right? Emergency services, law enforcement, as well as our outpatient and inpatient units, to really get a more full picture of what's happening with this person and those ideas that we have around what can we do to support.
And the frequent faces group, you know, we all know the same people, right? Fire has seen them, police has seen them, the hospital's seen them, crisis has seen them. And the problem with the scattered system is nobody's putting all the connection points together to get that holistic picture until now. Another thing I want to brag about to Amy's team with us. They also, I know she was a key person in us getting enough crisis mobile teams in our city to be meaningful. When we first started out on this, I think we had 2, now I think we have 11?
Depending on the time of day, depending on the day of the week, it's based on volume. So sometimes you got a whole bunch.
Yeah, and so the reason that's important is they're available to us. They're available to the officer in the field, who maybe we coded it as one thing because that's what they said, but when they got there, they actually found something else. So it extends it to the next level as well, not just what's happening in the comm center. And we even, they've even been, standing by as the SWAT team's there trying to negotiate with somebody instead of having a really negative outcome. Their team has assisted the law enforcement team or the EMS team in having a much more positive outcome because they know the right things. And their abilities and their capacity and capabilities is just greater. And then at the same time, police is there perhaps to join them on a scene that may be a little worrisome, that it's safe for those crisis responders to get there. So that partnership also, just extends beyond our center. We initiate it, but they also keep it going out in the field.
So Amy, the fact that we all have in common high utilizers of our systems, 911, 988, crisis services, whatever, we all have that in common, but what we don't have in common is co-location of services. But as you've mentioned, and I hope people slow down for it, there are resources available.
Absolutely. So like I said before, I'm selling nothing here. This is the crisis system that I represent. And then this offshoot, which is the connection directly to our emergency services, our 911 PSAPs, our law enforcement partners. That connection point is something that I have a whole team of folks that this is what we do. We foster those relationships. So no matter where you are in the state of Arizona, I can't speak to other states, but I believe, given the number of folks that have come in from out of state to visit how we're structured in Arizona, our financing structure, our funding structure, with our Medicaid dollars being braided for federal, state, and local dollars, the way that we are funded, and then the oversight of that through access, I believe that structuring is something that other states are probably looking at as a means to really sort of resolve maybe those conflicts or those jurisdictional boundaries. So from that standpoint, I'll say this is yours. Elected official, wherever you are in the state, to what degree your community wants to engage is completely up to you. We have a lot of contracted providers, and we work through contracts and we, negotiate, and then we oversee those contracts. When I'm working with first responders, there's no contract there. We have MOUs in place, sort of to understand the roadmap of how we work together, but I can't compel Tucson 911 to do anything, Tucson Police Department, Tucson Fire. This is a structure that's built that we can then customize to the needs of those communities that are interested in engaging. So if that means transferring a phone call, if that means maybe a dual dispatch, starting a mobile team out when you're sending out a first responder, if that means, a co-location as an option, we're interested in all of those options to try and create more opportunity to divert people off of the traditional emergency services routes that have been there, that then sort of perpetuate that fast track to the emergency room and that fast track to jail. So if we can get ahead of that right at the beginning, boy, can we make change for folks. And then that means our communities are healthier. It means that they are able to stay in their homes. They are able to take care of their families. They're able to keep their jobs and their supports. When we start to move people out of those support networks and we take them out, or we wait too long. I hear this a lot. We wait too long, right? Like it wasn't that big of a deal. We didn't want to engage crisis. We flip that and say, there is no call too small. Earlier intervention really does work. So let's try and look for the opportunity. If it doesn't feel like it's a first responder call, then it's probably a crisis call.
And you've said, Amy, 2 to 3% of your calls that get kicked over to your team come back to law enforcement or fire or for a field response. I hear this over and over and over again, that we're opening ourselves up to liability as a 911 system or as a municipality. Sharon, do you have something to say about that?
Right. Well, liability, right? Back in the day, all authorities having jurisdiction were given a simple rule: authority having jurisdiction shall respond to emergency calls for service. No one defined the word respond, and no one defined the word emergency. And so we collectively as an industry said, big red has to go lights and sirens down the street, no matter what, no matter how big, how small. But the liability of that big rig running down the street for a non-emergent issue that my EMT or my paramedic can't do much about is a huge liability. That's a real liability. The fact that that truck is now not available for the heart attack down the street and they're waiting for the next closest unit is a liability. Our ability to get that right resource, there's where the liability comes, is when we are failing or sending the wrong resources and an error happens or something goes south that way. So we've got to just kind of repurpose that conversation around liability and recognize where the other liability is. And I think most jurisdictions say liability means I should have sent police or fire and they didn't go today and I'm scared about that. So Amy touched on pilots a few times. I mean, that was how we got our, you know, our upper echelons to hear us, hey, let's just try it. And if it doesn't work, we'll back out, or we'll start small, we'll co-respond. We'll go together so we could start to, you know, be comfortable with each other's work. And that's where you find that relief, and really does lessen the liability rather than increasing it.
So seeing what you all are doing in Tucson is incredible. The resources from which you pulled are available for people across the state. And with that, this is our time. We, as I said before we started recording, I'm sure we could go for volumes, and we certainly could. But I want to thank Sharon, Anna, Amy for being here today and being a part of this conversation. So with that, the three of you, thank you for an incredible conversation. Appreciate it.
Thanks for having us.
Thank you.
For any information about any of the topics discussed today, please reach out to me, matt@cominote.org, matt@kominote.org. I'm more than happy to make connections to the resources discussed or any of our speakers who are more than happy to assist communities throughout Arizona looking to integrate crisis and public safety resources. Thank you again for joining us today. And until next time, I'm Matt Eckhoff.